Hello, good evening, everyone. Today we will continue our series of discussion on Harrison-based discussion, and that is on CNS symptomatology. In last lecture we have discussed about raised ICP and coma, and in previous lecture we have also discussed about dizziness, syncope, vertigo, LMN weakness, sensory motor weakness, UMN weakness. After that we have covered our raised ICP features, coma features, and now we will covering new symptom new symptom in CNS, that is your dementia. Okay, everyone. Ma- is audio okay? Everyone, just give me a thumbs up if audio is okay. Hello, everyone. Audio okay? Just give me a thumbs up if audio is okay. Then we will start. So today's our all discussion is about dementia. And when someone says to us, na, ki dementia, okay, Venki, good. So today our discussion is all about dementia. Now, dementia is a neurological symptom. But what I generally think, na, at undergraduate level or at a PG level, also our understanding about dementia is not that much clear, na, because generally we don't take proper history or we. Hello, Madhu Manjiri, how are you? You were missing from many classes, last classes, na. So when it comes to dementia, so generally we don't have a proper knowledge how to take proper history and how to take ex take proper history, take proper examination of dementia. And maximum time our knowledge about dementia is not that much clear when it comes to undergraduate level, postgraduate level, because generally we try to skip this topic now. So in here this lecture, we will before we discuss about dementia, we will first take in into consideration a brief discussion about about memory, because generally what we think in our past or currently in some doctors also now that dementia is all about memory, but things have changed in many ways now. Today it's not only about memory, it's also about many other cognitive functions. So before we begin about dementia, we will first into take what is memory, how we define memory, what is short-term memory, what is long-term memory, and all things. Okay, so can anyone tell me what do you understand by term memory? Anyone? What do you understand by term memory? So it is the, you can say, a function of a brain. You can say it is a function of brain by which a data or information is encoded, stored, and retrieved when needed. So what do you understand by memory? It is the function of brain by which a data or information is encoded, stored, and retrieved when needed. So generally, suppose we have to understand a topic, we have to write that topic in our exam. So when we are going to exam, suppose I have studied last day I have studied about particular topic, and yes, and tomorrow I'm going to give exam. So at the time of exam, I need to retrieve that information. I need to retrieve that information, and from where that information will come, it will come with the help of our memory. So memory is an integral part to know anything, to understand things, and to retrieve that information again. So that is the function of memory. So it is the retention of information over time for the purpose of influencing future action. Okay, so when we know something, when we have retained some information, we can influence our future action according to them. Because if we are knowing something, then only we can implement that thing. And by the help of memory, we can do these kinds of function. So now we'll proceed to classification of memory. Classification of memory. So our memory generally classified into three parts. First is your immediate. First is your first is your immediate memory. So can anybody tell me what do you do? What do you understand by term immediate memory? Anyone? What do you understand by the term immediate memory? Anyone? Second is short term memory. And third is long term memory. So can anyone tell me what do you understand by term immediate memory, short term memory, and long term memory? Hello, Dr. Harris, how are you? So anyone, what do you understand by term immediate memory? Anyone? So what do you mean by immediate memory? So it is also known as working memory. क्या बोलते हैं इसको और working memory. So suppose uh, right now I'm going to some place and suddenly someone come to me and I was asking about where do you live, from where are you are. So what he says, so we will meet tomorrow. So when he says to me we will meet tomorrow, I just ask about his phone number. So he has given me his mobile number and he has say there's something like 98234647, something like that. So when he went, I suddenly opened my phone and suddenly my, yeah, Harry. So suddenly I typed that number. So the phone number which he has said to me, I can only remember that phone number up to max up to 5 minutes, 10 minutes, or max to max up to 10 to 15 minutes, not more than that. So he has said to me a number. I have typed on my mobile. I have saved that contact, and after some time, I have forget that. So this is a working or immediate memory. It stays for us for a particular second, a particular minute. It does the function, and then it is deleted from our system. It is deleted from our system. So a memory which stays in our mind for generally around 5 to 10 minutes, and after that it is deleted from our system. It is generally known as immediate or working memory. It is known as immediate or a working memory. And where it is stored? It is stored in prefrontal cortex. It is stored in prefrontal cortex. So, for example, any mobile number. Okay. Then comes your short-term memory. So, can anybody tell me how? What do you mean by short-term memory? Anyone? Can anyone tell me what do you mean by short-term memory? What do we mean by a short-term memory? Anyone? Harris is saying around till 30 seconds. No, no. When we when we say a short-term memory, we also call it as a recent memory. We call it as a recent memory. Suppose you are going to some place, going to some cafe, and suddenly someone comes to you and he is having conversation with you. Okay, so if that conversation is important or not, that depends on certain other factor. So someone come and he's narrating a story of his or her, and you are listening to that story. So if that story is not important, if that story is not important to you, you will keep that story in your mind up to how much time? Up to 5 minutes, 10 minutes, 30 minutes, and after some time, after 1 day or 2 day, you will forget that story. So that was a short-term memory. Suppose you are visiting a place, and when you are visiting a place, suddenly some few individuals come. Suppose your colleague come, or your boss come, or some other clerk come to you, and or any waiter come to you. You will see his face, you will remember his face, but up to how much time? Up to minimum of 1 or 2 days. After that, you will forget that. So that is a short-term memory, a recent memory, a memory which is full of recent incidents only. And after few time, it will be also be deleted. So it stays for minutes to hours. It stays for minutes to hours. And can anyone tell me what is the center for short-term memory in your brain? What is the center for short-term memory in your brain? Your center is hippocampus. It is your hippocampus. So your short-term memory is stored in hippocampus, which is part of medial temporal lobe, which is a part of medial temporal lobe. So you are having immediate memory, a working memory, which which is controlled by your prefrontal cortex. Okay. Then comes your short-term memory, which is a collection of all your recent memory, which is done by your hippocampus, or hippocampus is a part of your medial temporal lobe. That is your short-term memory. Next is your long-term memory. So how does someone decide कि this memory will be short-term or this memory will be long-term? So suppose I am sitting somewhere uh, at around I am sitting somewhere. First, one individual come to me, and he or she is speaking to me about some incident they have suffered in their life. And suppose the first person which has come to me, he or she is not that much important to me. So he will narrate me story, I will listen, and after some time I will forget. But suppose if that person is important to me, then I will listen his story and I will remember it for a long time. So for remembering it to long time, it is known as long-term memory. It is for when it stays for more than days. It stays for more than days. So person comes to me, he narrates his story. It will be stored in my hippocampus. That is my short-term memory. Okay, sir. After that, if I think, if I think that information is important, if I think that information is important to me, or if any incidents related to that information, what I will do, I will I will retrieve that information again and again in my mind. And if I am retrieving that information again and again in my mind, some neuroplastic changes will happen in my mind. Some neuroplastic change will happen in my brain. So that memory for hippocampus area will be now shifted to long-term memory. That memory from short-term hippocampus area, then it will be shifted to my long-term memory. So yeah, Harris. So there are three types of memory. One is the immediate working memory, other is short-term memory, and third is your long-term memory. Immediate memory is, suppose some people are going, you are sitting somewhere, some people are roaming here and there, and someone is giving you his or her phone number. So that thing you will remember how much time? For 5 minutes, for 10 minutes, max to max, and after that you will forget it. Then it comes to a short-term memory, a memory which you remember for around days, around hour to days, related to some number of people you met today. Suppose you have cooked something. Suppose you have cooked dal. Today you have cooked dal. So you will remember. That is the short-term memory. But long-term memory is when a short-term memory is important to you, when a short-term memory is important to you, you will revisit that memory again and again because that is important to you. And due to some neuroplastic change, that short-term memory will now be shifted to the long-term memory area. Yeah. So long-term memory, it is in neocortex. It is in neocortex. So immediate memory is in your prefrontal cortex. Short-term memory is in your hippocampus, that is the part of middle temporal lobe, and third is the long-term memory, which is stored by your neocortex. That is your cerebral cortex. 90% of cerebral cortex is your neocortex. So if there is a short-term memory, if there is a short-term memory, okay, and this memory is important to you, is important to you, okay. So what do we will do? If something is important to you, you will revisit that incidence again and again. Now suppose if you are going with someone, there is this individual for you which you have met your first time. Okay, this is the individual you have met first time, and you are going with that individual in car. Okay, so how much time you will remember that individual? 1 2 days, not more than that 2 days. But suppose if there is a fight with this individual, or this individual gives you some gift or any favor this individual does to you, so you will remember that individual for a long time. So why? Because he has done some favor to you, and that favor, or if there is some fight, that fight, you will revisit that fight or that favor in your brain again and again, and then this memory, which is in your hippocampus, which is in your hippocampus. Now, due to some neuroplastic changes in your neuroplastic change in neuron, it will be now shifted in your neocortex area. In your neocortex area. Okay, everyone? Everyone got this concept? How your memory from immediate, then comes your short-term memory, which is stored in hippocampus. And if that short-term memory, hippocampus memory, it is important to you, and if something is important to you, you'll revisit that memory again and again. And if you are visiting that thing again and again, due to some neuroplastic changes, that will be shifted from hippocampus to your neocortex area, and it will be converted into a long-term memory. Okay, everyone? Now, now we will see how we divide a long-term memory. How do we divide a long-term memory? So see, when it's come to your memory, there is your short-term memory, then is your working memory. Okay, sir. Then comes your long-term memory. Long-term memory is divided into two parts. That is your explicit memory and implicit memory. Explicit is declarative memory, and implicit is non-declarative memory. Okay. Your explicit or declarative memory is divided further into two parts. That is your episodic memory, that is your semantic memory. Then your implicit is divided into again two parts. That is your perceptual representation system (PRS) or your procedural memory or your procedural memory. It is also, we can say that it is known as conditioning memory. Also, it is known as your conditioning memory. Okay, everyone. Hello, Sharma. Good evening. So, short-term memory, working memory, immediate memory. Then comes your long-term memory. You divide it into two parts. That is explicit declarative memory and implicit memory. Your your explicit memory is divided further into two parts: episodic and semantic. And your implicit is divided into two parts. That is your PRS, and other is your procedural memory. So, see, this is your long-term. Good evening, Dheeraj. So, this is your long-term memory. This is your long-term memory. Okay, you will divide it into two parts. That is your explicit memory, and is your implicit. ठीक है, you have divided into two parts, that is explicit and implicit. Okay, now further you will divide this explicit memory in two parts, that is your episodic and semantic. Okay, and this implicit it in two parts. ठीक है, that is your classical conditioning, and other is your procedural skills. Other is your procedural skills. Uh, Maybe Puneet around 2 hours roughly. Okay, so we have divided our long-term memory in two parts: explicit, that is your declarative memory, and that is another is your implicit. Your explicit is episodic and semantic, and implicit is your classical conditioning and procedural skills. Now we will come one by one. First, we will come to episodic memory. So, can anyone tell me what do you understand by term episodic memory? Anyone? What do you understand by the term episodic memory? Anyone can tell me? Can anyone tell me what do you understand by the term explicit memory? Oh, sorry, episodic memory. Anyone? Memory about past event. Okay. Now, see, first we have to understand that in explicit memory is your conscious recall. Yes, conscious recall, because that is declarative memory, and implicit is there is not a conscious recall. Okay, done. Now we will first see what is our episodic memory. What is our episodic memory? No, no. Suppose yesterday I went to suppose yesterday I went to my friend's wedding. Yesterday I went to my friend's wedding. Okay. Now when I went to my friend's wedding, he introduced me to his wife. Okay, I have met to his wife. So that event, that event of wedding, I will remember in my life. And in that event, the special person I have met, that is his wife, I will also remember his wife. So this is the episodic memory. Event and things related to that event, I will remember. Event and things related to that event, I will remember. Suppose maximum time when there is birthday, and especially of girls. Suppose today is my birthday, and today there is something special in my breakfast. So generally, do I remember my breakfast? No, I don't remember what has been made in my breakfast. But suppose today is my birthday, so I will remember my breakfast which has been made. So someone, if after 2 or 3 months will ask me, "Hey, Nishant, when there was your birthday, what is there was in your breakfast?" So I will remember. Why? Because for me, birthday was important. So that event for me is important. And if suppose some event is for me is important, so all incidents surrounding that event, I will be remembered. So that is your episodic memory. Okay, everyone, got? So that is your episodic memory, and it is controlled by your hippocampus. No, no, no. It is not everyday event. A special event. See, a special event like your birthday, your marriage, your friend's birthday, and that marriage, and incidents incidents related to that event, and incident related to that event. Okay. And which center of brain stored this episodic memory? It is your hippocampus. It is your hippocampus. Now we will come to other memory. That is your semantic memory. That is your semantic memory. So can anyone tell me what do you understand by term semantic memory? Anyone? Can anyone tell me what do you understand by the term semantic memory? Anyone? What do you understand by the term semantic memory? So it is factual based memory. It is a factual based memory. Okay. So if I am asking to you, who is PM of India, you will say Prime Minister Modi. If I am asking to you, who is President of India, you will say to me. If I am asking you, who is the President of USA, you will say to me. If I am asking you about all the continents in this world, you will tell to me. So it is a factual based memory. That is a fact. It is a fact. And this memory is stored by your lateral temporal area. Yeah, general knowledge memory. So hippocampus is a part of your medial temporal lobe, your medial temporal area. Okay. So in explicit memory, there are two parts. That is your episodic and semantic. Episodic is by medial temporal lobe, and semantic is by lateral. Okay, first thing. And as as this episodic and semantic is part of the explicit memory, so you have to consciously think. Suppose if I am asking to you who's PM of India, you are thinking and then you are replying to me. You are thinking and then you are replying to me. So that is your explicit memory. You have to think. Suppose if someone comes, if the friend in which I have attended wedding. So my friend wedding I have attended, and there was incident that he told to me that this is my wife, so I have mated his wife. So suppose after 3 or 4 months he comes to me and he say to wife that in my wedding I have met you with my wife. So what I will say to him, I will first recall that event. So I am constantly recalling that event, and then I will say, yes, yes, I met your wife in your wedding. So you are recalling everything consciously. You are recalling things. That is your explicit memory. Okay, everyone, got? Now we'll come to your implicit implicit memory. That is your procedural skill and classical conditioning. So in implicit memory, in implicit memory. So as compared to explicit memory, in which you have to think consciously, here you don't have to think consciously. That is your non-conscious, non-conscious recall. So something is non-conscious recall. So where is your consciousness? Your consciousness is in your cerebral cortex. But now you are not thinking conscious way. So it is generally done by it is a subconsciousness, at a subconsciousness level. It is done at subconsciousness level. Okay. And so first was your procedural skills. First, your procedural skills. Now, what is your procedural skill? Suppose if I have learned driving, and it is about 1 year, 1 year I have done driving. So suppose after 2 or 3 months, after 1 year, I am again driving. So and someone is sitting with me and he is talking to me, but still I will be able to put my gear, first gear, second gear, third gear. I will be able to press my clutch, I brake, all things together, and still I am talking to her. So it means all that putting gear, putting clutch is at my now subconscious level. I don't have to think. So that is procedural skill. Driving, walking, swimming. It fits in your subconscious mind. Okay. So driving, like cycling, and it is at your basal ganglia. It is at your basal ganglia, cerebellum, and supplement supplementary motor cortex. Yeah, yeah, Puneet, you are right. So this is your procedural skill. After your procedure skill is your classical conditioning. Can anyone tell me what do you understand by term classical conditioning? Anyone? Can anyone tell me what do you understand by term classical conditioning? Anyone? What do you understand by term classical conditioning? So, generally, at the time of our evolution and at the time when we live in jungles, now, and also there is an example of a dog. So, what example? This example say that especially in your mammals, in all this type of beings, uh, a bell is placed and they ring the bell and suddenly they place food near the dog. Okay, they are doing this experiment again and again. And one time they place the bell, but they didn't give him food, but salivation started in dog mouth. But salivation started in dog mouth. This is your classical conditioning. Everyone got the concept of classical conditioning? Classical conditioning. Generally, it is in animals. Generally, it is in animals. Example: giving giving food to a dog after ringing bell. Okay. So see, now we have understood that we are having three types of memory. So just we will repeat with each other. First is your immediate. Okay, sir. Immediate is in your prefrontal cortex because you think with your prefrontal cortex. Okay, first is your immediate memory. Then comes your short-term memory that is stored in your hippocampus. Then comes your long-term memory, which is in generally in neocortex. Your long-term memory is divided into two parts. One is explicit and other is implicit. In explicit, you have to think consciously. Implicit, you don't have to think consciously. Then your explicit is divided into two parts. One is your episodic and other is your semantic. Episodic is suppose you went to a birthday party, that is your important birthday party, and you are remembering that birthday party and events related to that birthday party. So that is episodic. It is stored in hippocampus, only middle temporal. Then is your semantic. In semantic is your lateral temporal lobe. It is about your factual memory. In implicit, it is two types. Procedural skill, which is generally done at basal ganglia level, and other is your classical conditioning. In procedural skill is like your driving and swimming. Now, after finishing this, see this diagram. This is your prefrontal cortex. Okay, sir. In prefrontal cortex, what is stored? It is your immediate memory. It is your immediate memory or working memory. Okay, sir. Done. This is your hippocampus. So, can anyone tell me memory which are stored in hippocampus? Anyone? Memory which are stored in hippocampus. Just tell me in comment section कि हिप्पोकैम्पस में कौन कौन सी मेमोरी स्टोर होती है. एनीवन कैन टेल मी कि हिप्पोकैम्पस में कौन कौन सी मेमोरी स्टोर होती है. सो धीरज इज लाइक एपिसोडिक, मधु मंदिर इज लाइक शॉर्ट टर्म. तो दोनों होती है, एक होती है. दोनों होती है, एक होती है. दोनों होती है. सो फर्स्ट इज योर शॉर्ट टर्म, देन एपिसोडिक, देन कम्स योर देन कम्स योर एपिसोडिक लॉन्ग टर्म. ठीक है. डन सर. तो हिपोकैम्पस में शॉर्ट टर्म एंड एपिसोडिक लॉन्ग टर्म, एंड एपिसोडिक लॉन्ग टर्म में भी रीसेंट एपिसोडिक. कौन सी? recent episodic long term, recent episodic. अब see, why I'm why I'm stressing on recent episodic, because when you're suppose 2 days before some incident happened, that is a recent episodic. But if that episodic event, it is about 1 year ago, that episodic event has occurred 1 year ago, so that episodic event will also be termed in a long term memory. It will be in long term memory, but now it is not stored in hippocampus, it will go in neocortex, it will go in neocortex. Hello Arya, now so short term and your episodic long term. Okay. Then you can see that this is prefrontal cortex, semantic memory. So I have told you कि semantic memory कहाँ पे होती है? Lateral part of temporal lobe. So this is your infrolateral temporal lobe. Okay. Then is your procedural memory. It is in your cerebellum, in your basal ganglia, and your supplementary motor area. And working memory, that is your immediate memory, is in your prefrontal cortex. It is in your prefrontal cortex. So, done. Can anyone revise me with me? Sir, memory start from immediate working. It is in prefrontal cortex. Okay, sir. Then is your short-term memory. Short-term memory is in your hippocampus. Done, sir. Then it is your long-term. Long-term has two parts: explicit, implicit. In explicit, it is your episodic and semantic. Episodic is in hippocampus. Your semantic is in lateral part of temporal lobe, and hippocampus is your middle part of temporal lobe. Then, so we can say that explicit is in temporal lobe, episodic middle temporal lobe, and semantic in lateral temporal lobe. Then, when it comes to your implicit memory, that is a procedure skill, it is at your basal ganglia, cerebellum, and your supplementary motor area. Everyone, till now, have you understood this? Shall we move forward? Arya, Puneet, Dheeraj, Madhumanjari, understood till now? We move forward. Shall we move forward? Okay. Now, tell me one thing. You are storing memory. You are storing immediate memory. You are storing a short-term memory, and you are storing a long-term memory. But there should be area in your brain. There should be area in your brain which should help you to retrieve your memory. Which should help you to retrieve your memory, because either it is immediate, either it is short-term, either it is your long-term. You need to retrieve that memory, na, to know that memory again and again. So, which part of your brain help you in retrieval of memory? Can anyone tell me in comment section? कि retrieval of memory is done by retrieval of memory. Retrieval of memory. It is done by your prefrontal cortex. It is done by your prefrontal cortex. You will say, sir, कि prefrontal cortex, so it is storing immediate and working memory also. Yes, and retrieval of memory is also done by prefrontal cortex. So how much intelligent you are, so how much intelligent you are, it will be decided by your prefrontal cortex. Because if your exam is there, you need to retrieve that memory. And if you are having a good prefrontal cortex, you will retrieve many things. If you are having not good prefrontal cortex, you will not retrieve many things. So how much intelligent you are will be tell by your prefrontal cortex. Got everyone? Now we will study something about this prefrontal cortex also. So see, prefrontal cortex, prefrontal cortex is part of your frontal lobe. Okay. So see this diagram. This is your frontal lobe. This red and this blue. This whole is your prefrontal. So this is your prefrontal. This is your frontal lobe, and this part, it is your prefrontal area, and this part is your prefrontal area. See again. This is your prefrontal area. Okay. This is Broca's area also in your prefrontal area zone. So this is your prefrontal area. So we will know what all are the functions which are done by prefrontal area. Functions of functions of. Hello Rishali, good evening. So better today we are studying about memory. Okay. So now we have gone with the initial part of memory. Now we are studying about prefrontal cortex, which is in frontal lobe. So functions of prefrontal cortex. Then, sir, first is your personality. First is your personality. It means how are you? If you are soft spoken, if you are good spoken, how much intelligent you are, how much cunning you are, how much clever you are, how much soft you are, everything. Well, who you are is by your prefrontal cortex. Who you are that is done by your prefrontal cortex. So what personality you are carrying, it is by your prefrontal cortex. So if you think that someone is having good personality, he is good at some skills, and you are not, it means that he or she has a good prefrontal cortex. So who you are, it is decided by your prefrontal cortex. Okay. Second after personality is your intelligence. Is your intelligence. Third is your executive executive function. What do you understand by executive function? Now, so na, there are some individual. There is one individual who can't do one thing at a time also, but there are individuals who are managing four to five things at a one time. So how they are managing? That's by the executive function. You lay out your plan, how to do things, which things to done first, which things to done later. It is all decided by your prefrontal cortex. Good, Vishali, if you are a soft spoken person. So your personality, your intelligence, your executive function. Fourth is your abstract thinking. Then is your attention. What do you understand by attention? How much you are focused. How much you are focused if you are studying, if you are doing, if you are suppose you are playing cricket, how much you are focused if you are doing goalkeeping at the time of a football match. So how much focused you are when you are doing a particular task. Attention. It is also decided by your prefrontal cortex. Then is your retrieval of memory. It is also by prefrontal cortex. Then is your then is your language, and last is your appropriate social behavior. So what do you understand by all these things? We understand that who we are is by our prefrontal cortex. Suppose if someone say suppose some if someone is saying something about me, that he is like this, he is like that. So what does this mean? It is divided by prefrontal cortex. So your personality, how much intelligent you are, how much multitasking you can do, how good at you are at your language, how good at you are managing the your social behavior, how good you are managing at manipulating others, how good you are at dealing with someone, how good you are at your communication skill. Is everything is decided by your prefrontal cortex. So everyone got this, the concept of prefrontal cortex. Prefrontal cortex is the part of your frontal lobe only, and language is how prefrontal cortex is controlling your language, because in your frontal lobe is your Broca's area, and Broca's area help you in speaking. So in prefrontal cortex also has the Broca area. That's why it is also indulged in the language part. Yeah, good, Vishali. Okay, now there is one also interesting thing to know is that your prefrontal cortex, your prefrontal cortex, it is connected. Thank you, latest news. So it is about memory. Na non-medical should also know about memory. Okay, so prefrontal cortex, it is also connected. It is also connected with your subcortex. It is also connected with your subcortex. That is your basal ganglia, your striatum, and that is by frontostriatal fibers. ठीक है? So prefrontal cortex has some fiber and association with basal ganglia, that is a subcortex also, with help with with the help of frontostriatal fiber. So there are some fibers which are connecting your subcortex with the prefrontal cortex also. This one important thing you also has to remember. So we have done with prefrontal cortex part. Now we will move to dementia. So can anyone tell me the definition of dementia? Anyone? Can you tell me the definition of dementia? What do you understand by when someone say to you if this patient is suffering from dementia? Just tell me. What do you understand when someone say to you that this patient is suffering from dementia? Arya, now Rishal is like loss of memory. Okay, but that in the beginning of class I have told you na, Rishali, that demen- dementia means loss of memory, but sometimes dementia can also be without loss of memory. Sometimes, good Dheeraj. Dheeraj is saying it is about cognitive. Okay, Vishali, earlier our concept was like that dementia is all about loss of memory. But now onwards, we have created the concept that dementia is not only about loss of memory. It is about loss of cognitive function. And memory is one of the cognitive function. There are many cognitive function in which one of the cognitive function is memory. So it is not just merely about, you can say that memory loss is dementia. There are other factors also. If suppose if there is a person whose memory is okay, but there is something abnormal, there is some abnormality cognitive function also. So you can call that also dementia. So dementia is not only about memory loss, it is also about the other cognitive function also. Okay, so can anyone tell me? Harshita is saying to me that it is loss of cognitive function. Okay, done. So can anyone tell me what do you understand by the term cognitive function? Anyone? What do you do understand by the term cognitive function? What do you understand by the term cognitive function? Anyone? Uh, Dheeraj is saying decision making. Harshita is saying like thinking, remember, reasoning. Okay. Anyone else? So see, what do you understand by the term cognitive function? It is acquire and manipulating manipulating knowledge. No, 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 no. It's not coordinative action. See, how can you think and analyze? You have seen that many of times what we say that child is not that much intelligent that adult is very much intelligent because as we grow our cognitive power improves. So what do you understand cognitive power? It means how much you can think, how much intelligent you are, how much you can analyze something, how much you can analyze something, how you can understand something. Suppose there's a problem of maths, you can understand that problem of math, but a boy who is in second or third standard he can't understand, but a adult, uh, a boy who's in 12th class, he can understand that maths problem. So it is about acquiring and manipulating the knowledge. How much you can think, how much abstract thinking can be done, how much deep you can go into something. So it is about analyzing, acquiring the knowledge, and cognitive function of us improves by our age. As we grow, our cognitive function improves, especially when were child, when we were small boy, small baby, and now we are 8th class, 9th class, 10th class, 11th class, then we go to college. Our understanding increases. You know ना, sometimes we say यार मैं पहले तो कितना पागल था, काश पहले तो मैं पागल था तब मैं ऐसे काम इसलिए करता था, पहले मैं पागल था इसलिए मैं ऐसा करता था, अब बस मेरे में समझदारी आ गई. सो यू हैव सेड ना that many times we used to say when we are sitting with our friends, यार पहले तो मैं बहुत पागल था अब मैं बहुत सही हो गया हूँ. So this is your cognitive function. This is your cognitive function. So Dementia is all about loss of cognitive function. Dementia is all about loss of cognitive function. So can anyone tell me what all are the cognitive function? What all are the cognitive function? Can anyone tell me what all are the cognitive function? विशाली पहले भी पागल थी अभी भी है अरे so see, I have told you that dementia is loss of no इमोशनल कॉन्सेंट से नहीं जुड़ा होता है सो इट इज अबाउट लॉस ऑफ कॉग्निटिव फंक्शन so suppose there is a human being who is having loss of cognitive function. So how can you know that someone is having loss of cognitive function? It is only by history. It is only by history. So examination, generally your motor and sensory examination is normal. Yeah, the patient who is having loss of cognitive function, generally their motor and sensory examination normal. Generally, how we get to know that this person is suffering from cognitive dysfunction? By taking a proper history. ठीक है now what do you understand by term dementia? Dementia means this person is out of mind. This person is out of mind. Because all time we used to say pagal hai. What we used to generally say pagal hai. But it is not about is only about pagal. So dementia is around out of mind. We are saying that this person is out of his mind. This person is out of his mind. So person will be having loss of cognitive function and loss of cognitive function you will get to know about by history. In these kinds of persons, generally motor and sensory examination is normal. Motor and sensory examination is normal. So what all are the cognitive function which we are having? First, so first is your first is your first is your attention. First is your attention. Second is your executive function. Second is your executive function. Third, third is your social cognition. Social cognition. Fourth is your memory. Fourth is your memory. And fifth is your perceptual motor. Perceptual motor. And last but not the least is your language. Is your language. So what all are the what all are the your cognitive function? It is your attention, executive function, your your social cognition, then is your memory, then is your perceptual motor, then is your language. So we are having six cognitive function. Now it is visible. Sorry. So we are having. Please, everyone, don't fight. Okay, it is blank. Wait a minute. Wait a minute. Maybe some connectivity issues there. Wait a minute. Wait a minute. Maybe it's something connect. Now it is showing. Maybe the color issue is there, na? Maybe. So first is your attention. Okay. Second is your executive function. Third is your social cognition. Fourth is your memory. Fifth is your perceptual motor. And sixth is your language. Okay, done everyone? Please everyone, Arey Rishali, don't fight. Harshita, Priyanka, don't fight. Okay. So we are having six cognitive function. That is your attention, executive function, social cognition, your memory, your perceptual motor, and sixth is your language. Now, can everyone tell me that your attention, executive function, and social cognition is a part of which loop? So we are having see, Dheeraj, we are having six cognitive function. We are having six cognitive function. Okay. In this, first is your attention, second is executive function, third is social cognition, fourth is memory, fifth is perceptual motor, and sixth is language. Now, everyone, Harshita, Dheeraj, or Rishali, just tell me the starting three function. The starting three function, that is your attention, executive function, and social cognition, is done by which part of your brain? Is done by which part of your brain? Rishali, Dheeraj, Harshita, can anyone tell me? The starting three cognitive function, that is your attention, executive function, and social cognition, is done by which part of your brain? Prefrontal. Very good, Madhu Manjari. It is done by your prefrontal cortex. Very good. So we can say that these three, these are done by prefrontal cortex. Done. Now tell me which part of your brain, which part of your brain controls memory? Which part of your brain controls memory? Which is most important part of your brain for memory? Which is the most important part of your brain for memory? It is your medial temporal lobe. That is your hippocampus. That is your hippocampus. Because hippocampus is a storehouse of short-term memory. And if you are storing a short-term memory, after that it will convert into long-term memory. Na? So short-term memory is really important. So which part of your brain is most important when it comes to your memory? It is your hippocampus. It is your hippocampus. ठीक है? Then is your perceptual motor. Then it is your perceptual motor. It is done by your parietal lobe. It is done by your parietal lobe. And the last is your language, which is controlled by temporal as well as by frontal lobe. Because in temporal lobe you are having Wernicke's area, and in frontal lobe you are having your Broca's area. So can anyone tell me? Yeah, uh, in next class I will tell you about this. Okay, कि ये वाला term कैसे originate हुआ? Okay, so can anyone tell me what do you understand by the term perceptual motor? What do you understand by the term perceptual motor? Can anyone just tell me what do you understand by the term perceptual motor? Can anyone tell me what do you understand by the term perceptual motor? Yeah, Rishali, tell us about what do you understand by the term perceptual motor? So, perceptual motor is new term, na? It is a combination of your sensory as well as your motor. It is a combination of sensory as well as your motor. Now, suppose right now I am playing cricket and I am standing on boundary. I am standing on boundary. Suddenly a catch comes to me. A catch comes to me. So by my eye, I am seeing that ball. So there is some sensory part involved in this because I am seeing that ball and I am also running. So my motor part is also involved. So my motor part is also involved. So perceptual motor is a combination of sensory and motor. It is a combination of your sensory as well as your motor. Suppose you are playing football. When you are playing football, you are juggling with the ball as well as you are seeing that goal box because you have to hit the goal. So you are seeing and as well as playing. That is motor part. So it is a combination of sensory plus motor. Okay, that is your perceptual motor. That is, and other is your social cognition. Can anyone tell me what do you understand by term social cognition? What do Sharma Puneet Rishali? Can you tell me what do you understand by the term social cognition? Anyone? Can anyone tell me what do you understand by term social cognition? No one. What do you understand by term social cognition? A complex set of mental abilities underlying social stimulus. No. So सोशल इंटरेक्शन किस तरह से करेंगे इंसान तक इज अ सोशल कॉग्निशन या काइंड ऑफ दिस आल्सो यू आर राइट विशाली बट इट इज अबाउट जजिंग मूड ऑफ अदर पर्सन judging mood of other person. Now suppose what I mean by judging other mode of other person. Now suppose if Rishali and uh, Sharma Puni, they are upset. They are both are upset. And I met to them. I go there and I'm meeting these two persons. So if they are upset, what should come in my mind? Yeah, they are upset due to some reason. So I should be become upset also, na? Because they are upset also. But suppose if due to some reason my social cognition power is gone, my social cognition power is gone. So if they are upset, and I will be like, I will be smiling because I am not judging their mood. I am not judging their mood. So social cognition is judging mood of other person and then adjusting your mood according to that, and then adjusting your mood according to them. Okay, suppose there is a teacher scolding to you again and again. So you will be like upset. But if your social cognition is gone, if your social cognition is gone, then you will not upset. So understanding by someone just by his facial gestures, understanding someone by just his facial gesture is your social cognition. Is your social cognition. So we all know about attention that is focusing somewhere. When it comes to executive function, it is about how are you managing things? How are you managing things? Suppose if I am going to make Maggie, if I am to go and make Maggie. So first, suppose if I am boiling water, then after boiling water, I am putting noodles into it, and after noodles, I am putting that Maggie masala into it. So this is the procedure. So this is the executive function. You are doing everything by a planned mode, in a planned and procedural mode. This is your executive function. ठीक है. Other is the social cognition that I have told you. Then is your memory, how you know something, how you can retrieve that knowledge. Then is your perceptual motor, that is combination of sensory and motor. Then last was your language. So if I draw a diagram, so if everyone just draw a diagram with me, suppose this is a Kargil, like we should not judge others. Sir. No, no, no. It is not about judging someone. It is generally about that if someone is upset, we should be upset also because that is the social cognition power. to judge anyone by its facial gesture. Okay, na? You can't be laughing if someone is upset. Okay, Kargil. So see, this is your this is your prefrontal cortex. This is your prefrontal cortex. And what things it controls? It controls attention. It controls attention. It controls executive function. It controls executive function. It controls your social cognition. ठीक है? All these are done by your prefrontal cortex. Yeah, Rishali, you are correct. And now this is your this is your temporal lobe. This is your temporal lobe. And what function it has? First, it will be doing memory. It will be doing memory with the help of hippocampus. With the help of hippocampus. And other is your language part. Other is your language part due to with the help of Wernicke's area. With the help of Wernicke's area. Okay. Then comes your this area. This is your parietal lobe. This is your parietal lobe. And what function it controls? It controls your, if this is 4, this is 5, this is 6. This is your perceptual motor. Rishali is like, sir, Rakhi celebrate. No, Rishali, doctors don't have time. I was busy in preparing the this lecture. Okay, so everyone have got this with diagram. See this area. You just draw a lateral section of brain, then you draw a prefrontal cortex. In prefrontal cortex, your three areas done, sir. Then comes your parietal lobe. It is concerned with perceptual motor, and then is your temporal lobe, which have function of memory, language. Language somehow is also about the frontal lobe also. Frontal lobe also, because frontal lobe has a Broca's area also. It has a Broca area. So language have two areas, frontal and temporal. So now just I am drawing diagram. Now you all will tell me. If hi, humor. So this is your temporal lobe. This is your temporal lobe. So tell me the cognitive functions which are controlled by your temporal lobe in comment section. Tell me the cognitive function which are controlled by your temporal lobe. Rishali, Sharma Puneet, Harshita Priyanka, just tell me the cognitive function which are controlled by your temporal lobe. Memory and language. Yeah, I have done that. Yeah, Rishali, I have done that. Yeah, very good. It is memory and is your language. Okay, very good. Now, tell me, this is your parietal lobe. This is your parietal lobe. And which cognitive function is controlled by your parietal lobe? Which cognitive function is controlled by your parietal lobe? Just tell me in comment section. Parietal lobe controlled which cognitive function? Perceptual motor. Very good. It is perceptual motor. Very good. Then last but not the least is your prefrontal cortex. It is your prefrontal cortex, which makes your personality. Which makes your personality. Yeah, sensitive motor. Very good. So by prefrontal cortex क्या क्या आपका? It is your attention. It is your attention. Second is your executive function, and third but not the least is your social cognition. Yeah, very good. So we have done with all the cognitive function. We have understood the concept of all the cognitive function, that is attention, and we have also done with the lobes of all the cognitive function. किसी को कोई डाउट कॉग्निटिव फंक्शन में, जस्ट टेल मी कमेंट सेक्शन, देन वी विल मूव फॉरवर्ड. जस्ट एनीवन, किसी को कोई डाउट कॉग्निटिव फंक्शन में, टेल मी इन कमेंट सेक्शन, देन वी विल मूव फर्दर. ठीक है. ओके. सो नाउ वी विल कम टू now we will come to the DSM-5 criteria. DSM-5 criteria. So DSM-5 criteria of major neurocognitive disorder. ठीक है. So dementia is now called as major neurocognitive disorder. Is known as. So amygdala is all about your conditioning memory. Kargil, it is about conditioning memory. So I have told you na, if there is a dog and I'm ringing bell again and again, and I'm producing food. So saliva will come, he will eat food. But a time will come, I will ring the bell, but I will not give him food. So, but saliva secretion will be there. So amygdala is about conditioning memory. It store your conditioning memory. That is part of your long-term memory, and in long term, that is a part of your implicit memory. That is the function of amygdala. Okay, Kargil. So dementia is major cognitive disorder. It is major cognitive disorder according to DSM-5. So earlier, it was known as dementia, but now DSM-5 criteria called dementia as major neurocognitive disorder. So, if there is some major neurocognitive disorders, there will be some minor also. So, what is it? So, see, earlier there was a term known as MCI. Earlier, there was a term known as MCI. It is now known as minor neurocognitive disorder, according to DSM-5. According to DSM-5. Now, you will ask me, sir, what do you understand by the term MCI? Do you understand by the term MCI? So MCI stands for mild cognitive impairment. Mild cognitive impairment. So how will you distinguish between this patient is suffering from mild cognitive impairment or dementia? Because MCI, that is a mild cognitive impairment, it is known as your minor neurocognitive disorder, and dementia, it is known as your major neurocognitive disorder. How will we differentiate between them? Differentiation factor is that in dementia, that in dementia, your daily activities, your daily activities hampers. Your daily activities hampers. Okay. So when there is when there is when there is loss of any cognitive function, plus if your daily activities are getting hampered, then it is known as your dementia. But in MCI, your daily activities are normal. Your daily activities are normal. So by this you can distinguish between it is an MCI or dementia. Yeah, Puneet, you are right. ठीक है. तो सबको समझ गया एमसीआई और डिमेंशिया का फर्क क्या है. एंड जस्ट आई विल ड्रॉ ग्राफ विद यू आल्सो. सी दिस ग्राफ ना. So we all know that generally when we go old, generally when we ages, our memory decreases. Our memory decreases and chance of dementia increases. We know na ki if this patient suffering from old age, now he doesn't remember all the things. So see, if I draw a graph, okay, and in this section, it is your age. This is your age. And suppose if you are 0, 20, 50, 75, and now suppose it is around 80. Okay, this is loss cognitive function. Suppose this is around 25%, 50%. Now it is your 75%. Okay. Now, if there is a patient generally in starting would be a normal patient. Then after some time, this patient will progress to MCI. Okay, there will be loss of cognitive function, but daily activities will be normal. But and after some time, this same patient will progress to dementia. Will progress to dementia. And our aim is to treat the patient here at MCI. Because if we start treating the patient at MCI, then chances of this patient will go to dementia will decrease. Then chances of this patient to dementia will decrease. So our aim is to catch the patient at this point at MCI. If we catch the patient at this point MCI, the chance of that patient to go dementia will decrease. So initial patient will be normal, then he will land into MCI, and then later he will be landing into dementia. And our aim and our target is to catch the patient at this point MCI. Now, generally, when we are around 75, our cognitive it decreases. It decreases. Suppose something around 10%. There's a decline of 10%. Okay. And after when you are suppose you are around 80, suddenly it jumps up to 40%. And after that, when you age, it generally jumps to 70% also. Okay. What it means that after your 60s or 70s, after your 60 or 70, the loss of cognitive function starts very rapidly. After you are 60 or 70, na, the loss of cognitive function spreads very rapidly. That's why in foreign countries, in developed countries, because their medical facilities are very good and they are keep tracking their health status very much well. So maximum patient they are living very old, and if they are living very old, they all have a chance of dementia. That's why the dementia problem is very much severe in foreign countries as compared to India, because in foreign countries they are living very much old. So if they are living old, everyone will face this problem. And when you are above your 70s, your 60s, your 80s, this problem of loss of cognitive function it increases rapidly. It increases rapidly. That's why in foreign countries there are many dementia nursing care center. There are many dementia nursing care center in which they keep tracking the patient, and they keep caring of these patients of dementia. Okay, अभी सब कोई ग्राफ समझ में आ गया. Patient initially will be normal, then MCI, then there will be dementia. You have to catch patient at here, at MCA. And as you age greater than 60, as you age greater than 60, the cognitive decline increases very rapidly. Okay. So now we'll move to the criteria. So DSM-5 criteria for major neurocognitive disorder, that is your dementia. So what it is saying that evidence of significant cognitive decline. क्या evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains. मतलब if you are having a cognitive decline, if you are having a cognitive decline in any one domain, in any one domain, that is your attention, your executive function, or learning, memory, language, your perceptual motor, or social cognition, we will calling it as a dementia. We will be calling it as a dementia. Okay, everyone? So, if there is a patient and उसको किसी भी cognitive function में क्या है प्रॉब्लम है, एनीवन कोई भी उसके छह में से हो अगर है तो वी विल कॉल इट एज अ डिमेंशिया. फर्स्ट थिंग. सेकंड, द cognitive deficits interfere with the independence in everyday activity. I have told you na, it should interfere with the daily activities done, sir. And third thing, the cognitive deficits, the cognitive deficit do not occur exclusively in the context of delirium. Do not occur exclusively in the context of delirium. So what he is trying to say? He's trying to say that whenever you are labeling the patient dementia, just first rule out that delirium. First, you always rule out that delirium, then you should label that patient a dementia. And third, the cognitive deficits are not better explained by another mental disorder. So suppose if there is a patient who's a patient of depression, So before labeling any patient dementia, you should first rule out that is he or she not suffering from depression, or if they are not suffering from delirium. So this means that dementia, first, one out of six cognitive function loss done, plus daily activity should be affected, done. And third, you should rule out you should rule out delirium. You should rule out delirium. Another thing you should rule out, that is your depression. That is your depression. Everyone got this definition? Dementia, one out of six cognitive function law, done, sir. Then comes your daily activity should be affected. Your daily activity should be affected, and you should rule out delirium, and you should rule out depression. Everyone, okay? Till now, got the definition of dementia? ठीक है. So before we proceed further, we should be able to distinguish between कि dementia and delirium में क्या difference है, and dementia और depression में क्या difference है. So first, can anyone tell me what do you understand by the term delirium? What do you understand by the term delirium? So just tell me now, before we proceed the term delirium, we should be able to know the few terms. So what is the term? First, that is your orientation. That is your orientation. Can हाँ यार विशाली, I will be telling you delirium कैसे rule out करते हैं. First, you will tell me few terms. What do you understand by term orientation? What do you understand by term orientation? When we are saying that this person is oriented, when I am saying that Puneet is oriented, Madhumanjari is oriented, what do you mean by the term orientation? Anyone? What do we understand by the term orientation? हम बोलते हैं ना, we are when we doing CNS examination, oriented to time, place, and person. Very good. It is oriented to time, place, and person. Okay, very good. Now tell me, what do you when do you call that person is confused? When do you call that person is confused? Anyone? When do you call that person is confused? We call that person is confused when the person is disoriented. When person is disoriented. When person is disoriented. So orientation क्या है? When you know time, place, and person. Right now, where I am? Right now, time is 8:25 p.m. Done. Place. So place. I am in Delhi. Person. I am Nishant. This is orientation. Con- Next is confusion. When we call the person is confused, when this person is disoriented, when this person is not oriented to time, place, and person. Very good. Third. Now tell me the definition of delirium. Now tell me the definition of delirium. Now tell me the definition of delirium. We know the term orientation, we know the term confusion. Now tell me definition of delirium. No, no, Naveen. Disoriented with place. So that is confusion. Tell me. See, orientation is time, place, person. Confusion is disoriented. Okay. So क्या delirium confusion same है और delirium confusion अलग है? Just tell me. Are delirium confusion same or confusion delirium same or there is something difference between them? So see, confusion is a broad term. Confusion is a broad term in which delirium comes. Confusion is a broad term. मतलब in confusion many things come. One of the part of confusion is delirium also. One of the part of confusion is delirium also. So when we are saying that this person is delirium, it is acute. Mark my word. It is acute confusional, acute confusional state. It is acute confusional state with increase increase in psychomotor, increase in psychomotor activity with fluctuating fluctuating level of fluctuating level of, just complete the sentence, with fluctuating level of or with fluctuating level of confusion or orientation. Yeah. See, now suppose a patient of confusion, a patient of confusion can also go in coma also. Sorry, not in coma. A patient of confusion can be less active also. He can be what Sharma is saying, delirium affects mainly awareness, attention, dementia mainly affects memory and cognitive function. No, but at the time, at the moment, you can't. Sometimes you can't distinguish. So delirium is first. Delirium is always acute, and your dementia is progressive. One thing. It is with increase in psychomotor activity with fluctuating level of orientation. So I will tell you, there was patient in my ward, and this patient in my ward is of meningitis. Is of meningitis. Okay. Now he was suffering from, now after 1 or 2 days we got to know that this person was of viral encephalitis. Okay. So in viral encephalitis, person is always in acute confusion state, that is in delirium. So suddenly when I went to that patient, because I was taking sample, that person suddenly kicks me. That person suddenly kicks me. So patient was acute confusional and he was kicking to me. He was kicking to me. Suddenly he kicks me and I got injured at my leg. He kicks me because there is also increase in psychomotor activity. There was increase in psychomotor activity also. Okay. But there can be patient of confusion which are not that much active. So when we are leaving a patient delirium, what we see that patient should be acute confusion state. Okay. And there should be increase in psychomotor activity because the patient in my ward, which was suffering from viral encephalitis, when I was taking his or her sample, he suddenly kicks to me because he was psychomotor active. He was psychomotor active. And other is the fluctuating level of orientation. What do you understand by this? Suppose there is a patient of delirium. You are seeing that patient in morning. In morning, that patient will be maximum time all right. Okay. But when day progresses and when there is night, you meet him again, you will see the patient was confused. But in dementia, patient patient cognition remains same throughout the day. Patient cognition, memory, everything, it remains same throughout the day. But in delirium, his confusion orientation changes with time and day. Sometimes he will be okay. Sometimes he will be very much upset. Sometimes he will be very much confused. Sometimes he will be confused a little bit. So delirium, always a fluctuating level is there. In dementia, fluctuating level is not there. Other delirium is always acute, but dementia it is subacute or chronic. It is a long-standing condition, and maximum time delirium is treatable. Delirium is treatable. maximum time. But when it comes to dementia, only 10 to 20% of dementia are reversible. Not all dementia are reversible. But when it comes to delirium, maximum time delirium is reversible. And there are many factors leading to delirium. That is your hyponatremia. Suppose there is a patient of in ward admitted of hyponatremia. Yeah, Rishali, it happens to me quite time. One time there was a patient of enteric encephalopathy. There was a patient of enteric encephalopathy. And she was a female around 18 years old. So when I was taking history to her, when I was taking history, she was speaking foul language to me. She was speaking foul language to me. Okay. Another time there was a boy of around 12 to 13 years old. When I went there, he was fighting with me. So patient, many of time, maximum time you will experience this, that patient will be acute confusion state and will be having increase in psychomotor activity. Okay, so delirium maximum time are treatable because they are generally by a metabolic. Because when you are in medicine wards, na, maximum time you will get that patient will be having a delirium and you will check his electrolyte. Maximum time he will be suffering from hyponatremia. So acute confusion state will be there. He will be hyperactive. And when you treat his hyponatremia, delirium part will be go. This how delirium. It is acute and quite treatable. So metabolic, it can be UTI also. Yesterday, in my ward, a patient was admitted. He or she was not passing urine for 1 or 2 days, and the patient was on altered sensorium. After that, when we insert poly, when urine was collected in bag, and we start antibiotics, and her when UTI part was improved, the patient improved and delirium part was settled. So this how you have to deal. Bharat is like, sir, what is the optimum number hours to study and sleep? So if you are asking to me how I study, it is like you study whole day, and whenever sleep comes, you sleep. You study whole day, and whenever sleep comes, you sleep. That's all. Okay, Bharat, study whole day. Whenever sleep comes, you just sleep. That is the motto when you are preparing for NEETPG exam. Okay, so metabolic UTI, it is maximum time treatable. So delirium versus dementia. Okay, delirium is short-lived. Dementia is chronic. It affects generally attention. It affects, yeah, very good. It affects memory. It is reversible. Only in 10% patient it is reversible. See, see, Bharat, I will tell you one. Okay? When it comes to sleep, when it comes to sleep, I will I will tell you about sleep also, Bharat. Wait a minute. So first you will understand the difference between delirium and dementia. But delirium tremens is something different. Okay. Now we are not here focusing on delirium tremens. It is something different. It is on of alcoholic. That is something different issue. Here we are distinguishing delirium and dementia. We will study delirium in some other class. Okay, beta? Sydney. It is only in 10% patient it is reversible, and other it is irreversible. That. So this is the difference between delirium and dementia. So Bharat was asking me about sleep. See, sleep is all about memory. Sleep is all about memory because when you sleep, there is reconsolidation. There is reconsolidation of your memory, of your memory. ठीक है? Sleep is all about reconsolidation of memory. So how good you are at sleep, how then it will directly proportional to your memory. So how good you are at sleep, then it will directly relate to your memory. So if you are having a 6 to 8 hours of sleep, then your memory will be good. Okay. Now, if suppose if there is a guy who sleep less, who sleep less. Now, when you sleep less, now if you sleep less, if you sleep less, your memory decreases. Your memory decreases because there is a some concept of like G lymphatic system. G lymphatic system. G lymphatic system. Like in body, there is a lymphatic system. Na? In brain, there is a G lymphatic system which clears your brain, which clears your brain. And especially in the sleep, it clears your brain. It clears your brain in sleep. So if you are not sleeping properly, your brain will be not be clearing properly. So it will be impairing your memory. It will be impairing your memory. It will be impairing your memory. And you know, na, maximum time patient, you all know that most common cause of dementia is Alzheimer disease. Most common cause of dementia is Alzheimer disease. And it happens in old individual. Why it happens in old individual? Because in old individual, sleep cycles disturb. In old individual, in old individual, sleep cycle disturbs. That's why they are more prone for dementia. ठीक है? So, when it comes to your memory, sleep is the most important thing. If you are not sleeping properly, it will lead to impairment of memory and also carry the risk of dementia in future. It also carries the risk of dementia in future. And we all know the most common cause of dementia is your Alzheimer disease. And why old individuals suffer more from this dementia? Because their sleep pattern disturbed. Their sleep pattern disturbed. Okay. So the most important thing of your life is your sleep. सबसे important क्या है लाइफ में? स्लीप. उसके बाद है सब कुछ. मोस्ट इंपॉर्टेंट इज योर स्लीप. ओके बता. ओके रिशाली. डन. Now before before we move to further dementia, we will first understood that there are some causes of dementia. There are some causes of dementia which are reversible, which are reversible, and they are about 10 to 20% only. ठीक है? So what are these? So these all are with mnemonic dementia. That is your D, that is your E, that is your M, that is your E, that is your N, that is your T, I, and A. So D stands for drugs. D stands for drugs, like your benzodiazepines. E stands for endocrine, and especially your hypothyroid, especially your hypothyroid. Okay. Then your M stands for metabolic, that is your vitamin B12. Then E stands for your eye and ear. N stands for NPH, non-pressure hydrocephalus. T stands for trauma, and I stands for infections like your meningitis, and A stands for anemia. So why we have to see the reversible cause of dementia? Because maximum time if a patient is coming to dementia, if someone bringing to you a patient of dementia, maximum time you can't correct dementia because maximum time patient is irreversible. But suppose if there is some reversible cause of dementia, if suppose there is some reversible cause of dementia, if suppose if there is a girl. So this girl has bring his father to me. Okay, his father was of around 50 years old, and he was having some memory issue. Okay, so because initially we have to first rule out all the reversible cause. So when we check his vitamin level, his B12 level was low, and when we corrected that B12 level, her her father memory got back. So see how good you are doing the patient. If you are bringing a patient his or her memory back, then what can good more than you do to a patient. So that's why it is important when you are seeing a patient of dementia, when you are seeing a patient of dementia, you should always first you look about for reversible cause of dementia, because if you are able to see if there is any cause of reversible cause of dementia and you correct that cause of reversible cause of dementia, you are bringing the memory back of that patient, you are bringing the memory back to the patient. Okay, so you see how good when you are a doctor. See, that's the importance of a good doctor. So if you are bringing a memory back to a patient who was earlier was suffering from dementia, see, you are improving his quality of life also. You are improving the quality of life of his that person as well as his family member. So now onward, if there is a patient of dementia, if there is a patient of memory loss, first you will rule out any reversible cause, because you can correct the reversible cause, and there's always 10 to 20% of person who are having these reversible cause. So you first will look about the mnemonic dementia. D for drugs, E for endocrine, M for metabolic, N for NPH, T for trauma, I for infection, A for anemia. First, always look about the reversible cause of dementia because you can correct them. Everyone got this concept. Whenever you are seeing a patient of dementia, memory loss, first thing you have to do, you have to first rule out the reversible cause of dementia, because these only are the causes you can correct them. Because other diseases like Alzheimer, frontotemporal dementia, you can't correct them. You have to treat them lifelong, and patient quality of life will disimprove. But in these patients, if you treat them at a particular time and you treat them correctly, you can improve their quality of life. Okay, everyone, just give me thumbs up if you have understood the concept of reversible dementia. Now, before we move to further again, we have to, because initially we have also see the difference between dementia and delirium. Now we will see the difference between dementia and depression. Dementia, depression. Because in DSM-5 criteria, you have to rule out depression also. And depression is also known as your pseudo dementia. It is known as your pseudo dementia. So, who will tell me the difference between dementia and depression? The first and the most important. In dementia, relatives will tell you the problem. Who? Relatives will tell you the problem. Patient will be okay. But in depression, patient will tell you the problem. Patient will tell you the problem. So suppose if I am a patient who is suffering from Alzheimer disease, if I am a patient who is suffering from Alzheimer disease, so patient who generally suffer from Alzheimer disease, they doesn't know they are suffering from any disease. They doesn't know. Suppose there is a patient of Alzheimer disease, okay, and this patient due has went to a park, has went to park, and due to his memory loss, he now doesn't know how to go back to his home. Now he's sitting in park. Now his relatives are searching for him, and after 2 or 3 hours, they go in park. They found it. They found that man. Now when they found it man, the this man relatives, they were so worried. Where our dad go had went. But this dad was okay. He was like he has doesn't done anything wrong. He was okay. He thinks everything is okay. Why his relatives are in so much angry mood? Why are they so much crying? He thinks everything is okay. So in dementia, patient is not knowing about his problem. He will be okay. His relatives and attendants will be knowing about the problem. I'm repeating again. Suppose uh, here is my father who is suffering from Alzheimer disease. He has went to some park and he is not coming back. So I went there. I was searching and I was in angry. I was crying. When I went to my father will be like that. Why are you crying? What happened? Everything is fine. So for him there is no problem, but problem is for us. So the patient who is suffering from dementia, from Alzheimer disease, he doesn't think there is anything wrong. He thinks everything is okay. But compared to patient who is having depression, suppose if I am a patient of depression, I will tell to a doctor, sir, what I am thinking that I am not able to recollect the things. I think my memory is getting weak. I am not able to recollect the things. So in depression, patient will tell all the things. In dementia, relatives or attendants will tell that. Okay. Now, other second, clear cut idea of the onset of disease. Of the onset of disease. No idea. So what I mean by that if suppose if from today I got a problem with dementia, and dementia is a chronic condition, and how it will start? It will first start with the change in my day-to-day activities. So initially, I will be not know my person around me will be not knowing that how much minute changes are happening in my day-to-day activity. They will be knowing my problem only when a major things happen. So initially, there is no clear-cut idea ki when the disease start in dementia, because initially when dementia will start, you will there will be some change in your day-to-day activity, but your son, your daughter will be not knowing that thing, because they will be get to knowing you are suffering from problem when there's something major, when there's something major memory loss is there. Initially they will be also not knowing anything. But in case of depression, suppose today my breakup was there. Okay, suppose today my breakup happened, and from 3 months I am in depression. 3 months I am in depression. So when I will go to doctor, I will tell him that I am suffering from depression from 3 months. I am suffering from depression from 3 months. So there will be a clear cut onset of idea. There will be a clear cut onset of duration. कि disease कब से start हुई है. Okay. Next comes the third point. In this, only recent memory is gone. Only recent memory is gone. In depression, both recent plus remote memory is gone. So, suppose there is a patient with dementia of Alzheimer's disease. Okay, last night that patient went to a party. Okay, a wedding, and day after tomorrow, when his son is asking to him, "Ki Papa, yesterday you went to a party." So he was like, "No, I didn't went to a party." So in dementia, recent memory is lost. But suddenly, after few minutes, his old friend come. His old friends come, but he will be remembering his friend. So his remote memory is intact, but recent memory is lost, is there. But as to depression, in depression, both recent as well as remote memory loss will be there. Okay. Other patient of dementia, patient of dementia will give you wrong answer. Will give you wrong answer. But patient of depression will say to you that I don't know. I don't know. That's the most important. If suppose you are asking to a patient that yes, suppose uh, these are both the patient, there is one patient of dementia, one patient of depression. Okay. And you are asking to them that tell me tomorrow what you have eaten in your breakfast. What you have eaten in your breakfast. The dementia person will tell you something wrong. Suppose he has eaten chapati, he will tell you I have eaten bread. But the patient of depression will tell you that I don't know. Will tell you the I don't know. So dementia person, because he is not knowing, he is suffering from an illness. So he will say wrong answer. But the patient of depression, because he wants that his or her disease should be cured. Patient of depression wants that his or her disease should be cured. So he will try to convince you that I am suffering from a disease. So when you will ask him question, he will reply to you that I don't know. I don't know. Okay, Puneet, it's sad to hear you are that you are suffering. You are from last 5 months you were admitted in ICU, but still you are studying up. That's very good, yeah, of Puneet you. So Madhumanji is like in Viva, everyone give answer like I don't know. Okay. Other thing is that in depression, in depression, patient gives vague answer. Patient give vague answer. ठीक है? But if that patient is suffering from depression, he will give you near about answer. He will give you near about answer. So suppose I am asking you, I am asking a patient of depression 4 plus 3. He will be saying to me 8. But a patient of dementia will be saying to me 24. Okay, so that's the problem. In depression, he will give me near about answer, but in dementia, he will give me vague answer. Yeah, Manmohanji. So everyone has got how to differentiate between dementia and depression. How to differentiate between dementia and depression. So before we are labeling any patient dementia, we should first rule out the delirium part and we should rule out the depression part. So we know the difference between dementia and delirium. We know the difference between dementia and depression also. Okay, now now tell me the most common cause of dementia. Most common cause of dementia. The most common dementia is your Alzheimer disease. Okay, then is your diffuse Lewy body dementia. Then is your vascular dementia, and then is your NPH. Okay, now just tell me, everyone, should we take Alzheimer, diffuse Lewy body, vascular dementia, NPH in other class, or we should do in this class only? Because I think it will take around 2 hours more to complete this Alzheimer, diffuse Lewy body dementia, and vascular. Should we take in this class or in next class? I think we should take Alzheimer, diffuse Lewy body in next class tomorrow. Just tell me, we should take in this class or tomorrow? Yeah, uncle, you're right. So just tell me, should we take in this class or we should take tomorrow? Okay, na. So we will be taking our class tomorrow also, na. We will take a class tomorrow at 7 p.m. only. In that class, we will continue this section of dementia further. Okay. In this, because now what in this class we have studied, we have taken, okay, uncle, we will take tomorrow. Okay, done. So in this class, we have studied about memory part. What is memory? When you label a patient of dementia, and what are the characteristics of patient of Vishali, we will take tomorrow better, na? Because I think this class will go too much long, na? If we take, because it is already late and it will not complete in 1 hour. It will take around 2 or 3 hours more. So I think we should take class tomorrow, 7 p.m. Okay. Tomorrow we will finish this dementia topic. Okay. So today what we have all studied, I will first concise and then we will end this lecture. We have today study about memory. Memory is a function of brain to store data and to encode the data. Okay, we have classified memory in two parts: immediate, short term, long term. Short, short term memory, it is immediate memory. Immediate memory is your working memory. It is stored in prefrontal cortex. Short term memory is your recent memory. It is stored in hippocampus. Then comes your long term memory, which is generally in neocortex. Your When your memory is stored in your hippocampus due to some neuroplastic change, when you revisit that memory again and again, it goes in your long term memory component. That is your neocortex area. In long term memory is divided into two parts. That is your explicit and your implicit. Explicit are those memory in which you have to conscious recall. That is your episodic. You have to conscious recall. In semantic, factual, you have to conscious recall. And episodic is in medial temporal lobe, and semantic is in lateral temporal lobe. Okay, Rishali. Okay. Then then we have studied about prefrontal cortex. That is about your personality, intelligence, executive function, abstract thinking, your attention, your retrieval of memory, your language, and your appropriate social behavior. Then is your we have done with definition of dementia. That is loss of cognitive function. Okay, there are six cognitive function we have studied. That is your attention, executive function, social cognition, memory, perceptual motor, and language. Then we have done with the part that is definition of dementia. So we define dementia as any one out of six cognitive function, any one out of six cognitive function, plus you have to rule out delirium and you have to rule out the depression part. Okay, that is your definition. Then we have done differentiation between delirium and dementia. Your delirium is acute confusional state with a fluctuating level of weakness. In suppose you are visiting an ICU, but in morning patient was having good consciousness, but when you come to night, patient consciousness disimproved. That is your delirium. In dementia, orientation consciousness remains same throughout the day. Okay? Then is your importance of sleep. I have told you. Then comes to difference between dementia and depression. In dementia, patient will be not knowing about his disease. His relatives will be telling the disease. But in depression, patient will be telling you the disease. Most common dementia we have done, and we have done with the cause of dementia which are reversible, because maximum cause of dementia are irreversible. Whenever a patient is coming to you with the dementia, you first have to rule out the reversible cause of dementia, because you can treat these causes. Because you can treat these causes. And tomorrow we will be studying about Alzheimer disease and all the disease further. Okay? So thank you everyone for today lecture. Okay. Good night and bye. And please everyone be on time. That is 7 p.m. Okay. We will first begin with Alzheimer disease for tomorrow. Yeah, yeah. Tomorrow 7 o'clock we will take the dementia part 2.